Patient Wilfred Ayres talks to surgeon D.D. Monroe.
So, Mr. Ayres, if this proves to be a cancer of the lung, your outlook or your prognosis is almost 100% nil for any length of time.
Yes.
And with operation and complete removal of the tumor and the tumor-bearing area, you have a reasonably good outlook. But then once it's completed, the only thing to do is to go back to your job and live with optimism.
And quit smoking.
And quit smoking.
Wilfred Ayres will walk these streets again, but minus the cigarette and minus a lung. In a week, he will have a major operation which we will see and which may save his life. Last year in North America, 50,000 people died from cancer of the lung, a disease which has become a major killer only since the smoking of cigarettes has become epidemic. Many more thousands died of coronary heart disease or were disabled by chronic bronchitis, emphysema, and other illnesses which medical men the world over say can be related directly to the smoking of cigarettes. Almost 150 years ago, Charles Lamb wrote, "For thy sake, tobacco, I would do anything but die." Medical men say too many people are doing just that.
In view of man's history, and in view of this history of heavy smoking for a goodly number of years, would you care to give any opinion as to the relationship between his smoking and the fact that he appears now with the proven bronchogenic carcinoma of the squamous cell variety?
I definitely feel that it did have a relationship to the smoking, but I don't think we can prove it.
I think there's no question that prolonged cigarette smoking is responsible, I presume, for carcinoma. Certainly these people get carcinoma, and the logical assumption is the responsibility of the cigarettes. Now, what in the cigarette smoking is responsible for it, I don't think we can say at all. Whether or not it's tar or some other product of combustion is not at all clear. But I think the association is clear, and I think that it is certainly more than adequate to be acted upon in advising people whether or not to smoke.
And you will be the first one, I'm sure, will agree that there are other deleterious effects of smoking that perhaps haven't got the fatality of a cancer of the lung, but from an economic point of view and from the point of view of disabling a person, they're equally as important. And I'm talking particularly about the chronic bronchitic and the emphysematous people.
Coronary artery disease seems to have some association. Certainly there are some cases where this appears to be clear-cut. There is a time-honored association with Berger's disease. There is no doubt that there are a number of areas of medicine where you can get this deleterious association between disease and smoking.
I've done the stupidest thing. I've smoked cigarettes before having anything, 3 and 4 cigarettes as soon as I get out of bed, which is, I think, is no good to anybody. And my wife says to me several times, she says, "Why ever don't you stop smoking?" I always inhale my smoke.
Yes. What was the symptom or the reason that motivated you to seek the advice of a doctor in the first place?
Well, for the past 9 months, when I went to see Dr. Halley's, I'd had a streak of blood on my phlegm. See?
In your sputum?
In my sputum.
Yes.
So I thought, well, this has gone far enough, and my wife said, "Why don't you go and see the doctor?" So I said, "I will. I'll make up my mind one of these days." I didn't know what I was involving myself in.
But when was that? This is important.
Yes, I should say about 9 months ago.
And when did you go to the doctor?
It was a month ago.
Just a month ago?
Yes,
so
a month
you waited
ago.
8 months?
I waited 8 months. Yes.
Why?
Well, I thought it was a blood vessel I'd broken in when I coughed. But it wasn't.
I put these x-rays up here not specifically for you to completely understand them, but to give you a rough idea of what your problem is. Now, if you look at this x-ray here, you will see that you have a shadow which is generalized in the upper part of the left lung. And if you compare this to the right lung, you'll see that there's a difference in the degree of penetration on both sides. What this represents is that you have a complete obstruction with you, Mr. Ayres. The thing that we're all concerned about this day is the fact that this could very likely be a tumor that's obstructing your airway. This tumor is undoubtedly likely to be a malignant tumor. In other words, it's to be a cancer. And if it proves to be a cancer, the only satisfactory treatment is to remove it completely. This will mean that you will lose your left lung.
And the other lung is good, isn't it?
Oh, as far as we know, it's an excellent lung.
Excellent condition. So that is one reason why I think that the left lung should come out. Little did I know till I came in here that I had only a lung and a half or less.
All right, Mr. Ayres, we'll carry on with the bronchoscopic examination tomorrow, and after that there will be no further delay.
No.
If it's indicated, we'll take you to surgery.
Yes.
Now, Mr. Ayres, we're going to carry out this bronchoscopy procedure that I explained to you yesterday, and this is the instrument, and the light is on the end, and it's hollow. And we put this through your air tree, and this is just a simple diagram of your air tree with the lung at the side. Now pay no attention to this side. This is your left lung.
Yes.
And this is the part that is involved. In other words, this part of your lung, which is your upper lobe, is collapsed because there's something plugging the airway going into it. Right here you have a bird's eye view, so to speak, of the air tree as we look sideways through a special little instrument that's actually a miniature periscope that we can look at a right angle. And these openings here, which feed air into this upper lobe, are plugged. And the object of this is to put down the bronchoscope. We turn your head to the side to line it up, and we have it lying in here, the main airway going to the entire left lung. And then we look sideways into this left upper lobe bronchus, and we observe directly with the human eye exactly what the condition and the nature of that air tube is. And this is the object of the examination. I don't think it'll bother you very much.
No.
We'll do it under local anesthesia.
Sure.
We'll freeze your throat, and I think you'll find it very easy.
Okay then, Dr. Monroe.
Your tongue will get thick. And it will be a little difficult to swallow for you, so that'll be an indication that you start to get frozen. Okay, that's fine. We are ready to...
All right, now just lie down, sir. Fine, thank you. Just raise your head, sir. Raise your head. Now put it down. I don't think you'll find this examination will upset you at all. So just, what size is this? Number 7? 8. 8? That's fine. Just stick out your tongue, sir. And just relax. Nice and easy. Nice and easy. That's it. No problem there at all. Lungs. Could I have the portable scope, please? All right. Now we're right in your main airway now, Mr. Ayres. And we're looking down into your main airway, and we can see the two divisions. Now we have these little telescopic instruments that I was talking to you about, and we've got this through the hollow tube, and we're looking on the interior of your airway, and we can see it very nicely. I'll have a right angle scope now. Now we're going to put in the telescope that's a miniature periscope, so we can look sideways. And with this instrument, we're able to see side branches directly. You're doing very well, Mr. Ayres. There's no problem here at all, and we'll soon be finished. All right, Mr. Ayres, we're all finished. Just sit up, sir. I'll take this off your head. Just swing your feet over the side. Now, did we bother you very much?
No, Dr. Monroe, no bother, no trouble. I didn't feel very little.
Yeah. Well, we've determined that your right lung looks very clear, and the main part of your left airway is fine, and that our suspicions that the left upper lobe airway was blocked has been confirmed.
Yeah.
And so this is plugged, and it's plugged by a tumorous growth. So our next job now is to fix you up and to get rid of this, and we'll proceed with that next week. Sure. Okay, Mr. Ayres.
Thank you, Dr. Monroe.
Not all smokers have the reasons to stop that Wilfred Ayres has. But not all who develop cancer have the warnings he had either. Cancer is a silent killer, and more often than not does not proclaim its onset. And doctors now urge that those who smoke have x-rays twice a year. Too many smokers come with their problems too late, when surgery or radiation or other treatments cannot cure them. Breathing tests help determine how he will function on only one lung.
Deep breath and blow.
And if I ring the bell, you're going to give me a cigar, eh?
Oh, I thought you had stopped smoking. Blow. Keep blowing, keep blowing, keep blowing as much as you can.
I'm really interested in his oxygen uptake. This is really what I'm, vis-a-vis one lung against the other. Easy.
The capacity of each separate lung can be plotted on a spirometer.
That's all you need, isn't it?
That's all, and you can calculate it, sure. We just want one against the other anyways. I want, in case I have to
You coming? What's that?
take the whole thing.
I think we better give him some more Demerol, don't you?
This is the moment of truth. But they're bang on, you know. That thing's in there real tight. I mean, it's good. It's a good differential spirometry.
Physical examination was essentially unremarkable, apart from the fact that there was gross abnormality in the respiratory sounds in his left upper chest, suggesting a collapse of his left upper lobe. The rest of the physical examination was negative, and the chest x-ray was grossly abnormal. He's had extensive investigations, many of which are of little interest because they're essentially normal, including electrocardiograph and his pulmonary function studies.
An extremely healthy-looking man, and I think almost clinically you could tell that he wouldn't present a risk to surgery, and I think it's his only chance for a possible cure of his disease.
He has no evidence of cardiovascular disease.
None whatsoever.
May we see the x-rays?
Yeah.
Now, the radiological findings are such that they indicate an obstruction in the left upper lobe bronchus.
Would you call the remainder of his lung normal?
The remainder of his left lung is normal, as his right lung shows no evidence of any disease.
We took a biopsy from these tumor mass, and Dr. Bellon can tell us about the...
Yes, well, the biopsy showed a squamous cell carcinoma, there's no doubt about it.
And no symptomatology elsewhere that would suggest extrathoracic.
No, not at all, sir.
The pulmonary function studies will be more helpful in making sure that he has enough reserve to withstand this sort of surgery. Dr. Vega, have you got the...
Well, sir, he had vital capacity done, maximum breathing capacity, timed vital capacity, and pulmonary diffusing capacity with carbon monoxide uptake. The opinion of the pulmonary function consultant was, in summary, the findings reported above are reasonably good for a male in this age group.
The flow rates are perhaps a little bit down, not as much as I would expect with his long history of smoking. His diffusing capacity was normal. I wouldn't consider these a contraindication to pneumonectomy.
Dr. Pollock, any comments?
No, I agree with Dr. Monroe and with the general course of the discussions, and I think in this case, operation is the best way to proceed.
As a result of the anesthetic, you pile up secretions in your chest, and it's difficult for you to cough, and the breathing exercises can make this simpler for you. Yeah. So let's just check them again. Yeah. Right? Okay. You don't have to fear coughing after the operation, Mr. Ayres, because I'll be supporting your incisions. So just let's practice again with the breathing in and out. Short breath in, long breath out, and cough. In, and again.
There is little hope among medical men that those who now smoke will stop, despite new medical knowledge that much lung damage can be reversed by stopping. They only hope that examples like Mr. Ayres will cause non-smokers not to begin.
Good morning, Mr. Ayres. How do you feel about the surgery now?
Oh, the way I look at it is this. It's a must, through what Dr. Monroe and other doctors have told me. And I put myself into their hands completely. I mean, he told me once that he said a little while back there that he didn't give too much chance for my life, you see, not if I didn't have something done. I've heard that there's lots of individuals going around with one lung. As a matter of fact, there's a lady I know very well through daily contact sometimes in a store, you see, and she only has one lung, and I think that you can't tell any difference whether she's got one or a half a dozen.
Maybe I could recommend that you try to rest as much as you can and to relax as much as you can.
When I start to come to from the anesthetic, you call it?
Yes.
Yeah. Am I likely to get into a tantrum, like get mad or something?
No. You will wake up.
I had that experience once. They plugged the ether over here, and I was asleep at 7 o'clock, came round about midnight, the same, that was where I was wounded, you know, for my leg. Yeah. And that took about 12 of them and I was cursing everybody around me, you know. It wasn't funny. I lowered my...
Yes, well, Mr. Ayres, there is nothing to that.
Yeah, I just had my little doubts there because I wouldn't want to cause any commotion like that, you know.
No, you have no fear of that,
yeah,
no.
Well, I'm not going to say that it's actually done by smoking, you know what I mean? I've left it to the doctors to say that. But when I was told not to smoke, I have not coughed. And I should have taken my dearly beloved wife's advice years ago and cut down on the smoking, you know. Yeah. But sometimes you get into a little bit of sometimes you get into a jam, and first thing you do is pick out a cigarette, and you keep smoking and smoking and smoking, you know. When you're told that you haven't only got that the prospects in life is not very far ahead of you, you know, then you sit up and take notice, because life is sweet.
Blood pressure is 130. Mr. Ayres, we're injecting the pentothal in the intravenous now, and you'll just fall off to sleep very quietly, very pleasantly. You may notice a little peculiar taste or smell, something like onions or garlic. We're now ventilating only the right lung. The left lung is excluded from the airway. Blood pressure is 120. Now, we let the respirator, the automatic respirator, take over control of ventilation. Now we're ready to position the patient for the surgery. Just help position his legs properly, please. Heart rate is speeded up now.
All right, now, we're about to make the incision. Dr. Brindle, everything all right? This particular patient will undoubtedly take out a rib to facilitate the exposure.
Blood pressure is remaining at 90.
Heart rate.
Can I hold this for you?
Now, up to the second rib. That's 2, that's 3, that's 4, that's 5. This rib is riding high on it. Doyen. The other doyen, the right-hand doyen. There's something. What is it? Yeah, the suction. Can you hold that lung over? I think it's... you have a sponge stick, please, for me? No. That's why I left it. Sorry. Okay, so that's kind of small, isn't it? It's a large mass. It's going to come. That's the only place where it seems to be. It's going to come, but it's not the most favorable situation. Actually, this seems to be confined to the pulmonary artery. The aorta doesn't seem to be... No, the aortic window is clear. It's clear, yeah. It's not involved. And there's nothing in the mediastinal area up above. No. It seems to be mainly the pulmonary artery and maybe the superior pulmonary vein. Kind of feel it, sir? Well, we just have to work away till we get the thing cleared out. All right, we're just about ready to sever the lung. Now, what I have in my hand here is just the air tube, and the other air tube going to the other lung branch is here. This is a soft clamp. It's gentle to the tissues, and we'll clamp the air tube like so. Now, just give me a knife, please. I think that we should set that a little further down, Rob. There you are. Now, we'll sever the connections here, and as we do, Dr. Pafari keeps cutting it out. Now there we are. Here's what we've been after this morning, is to remove this lung containing the tumor mass, which I have in my fingers here. Dr. Beeland will take this and demonstrate it now. But all the big vessels and everything that come off the heart are all tied off here. This isn't the important side, of course. The side is next to the heart.
Now let's cut the lung completely so that we can have a good view of this neoplasm or tumor. We start from the upper lobe and we'll go down to the base of the lung. Here is the tumor in the upper lobe, occupying almost half of it. It's not a very large tumor, it's just, I would say, medium-sized. It is a hard white mass that you can see here. The rest of the tissue is soft and spongy, and this tumor is very hard. It is fairly well demarcated, and the definite prognosis can be established only after microscopic examination.
How do you feel now?
Oh, not too bad.
Not too bad. The operation's all over.
Thank you.
Yes. Try to keep your eyes open. Now, will you take a deep breath for us? Now, deep. And out. And in. Out. That's it. And try to give us a smile now.
Sure.
Wilfred Ayres has opened his eyes again on a world that wears a cigarette in its face. where he will have to live with temptations that confront a smoker wherever he looks and listens, where persuasion filters out of the mind of the beholder the consciousness of the harms that medicine now definitely attributes to cigarettes. A world whose governments are split between the revenues they gain from cigarettes and the responsibility they feel for the health of their peoples. A world that seems to have no ready answer to the question of how far laws should go in curbing the rights of people to make their own choices and take their own consequences. A world where the young are taking ever earlier to a habit that public health associations have estimated will claim the lives of millions who are now school children before they reach the age of 70.